Greetings all, our presentation was on lithium. Lithium, available as lithium carbonate and lithium citrate under the brand name Lithobid, comes in multiple formulations, including immediate and prolonged release tablets, capsules, and liquid solution. FDA approved for managing acute manic episodes and providing maintenance therapy in bipolar disorder for adults and children aged 7 and older. Lithium also holds several off-label uses, such as managing bipolar depression, adjunct therapy in major depressive disorder, treatment for vascular headaches, and neutropenia. Lithium is fully absorbed from the gastrointestinal tract with reduced absorption on an empty stomach. Once absorbed, lithium is widely distributed throughout body fluids and easily across the blood-brain barrier. It does not undergo liver metabolism and is eliminated unchanges with an elimination half-life ranging from approximately 18 to 30 hours. Lithium's exact mechanism is not fully understood, but it likely involves multiple second messenger pathways. It inhibits inositol monophosphatase, modulates G proteins, regulates gene expression for neuronal plasticity, inhibits enzymes like GSK3-beta and protein kinase C, alters sodium transport in nerve and muscle cells, and affects neurotransmitter metabolism, including serotonin and catecholamines, helping stabilize mood. Common side effects of lithium therapy include gastrointestinal disturbances such as nausea, vomiting, dyspepsia, and diarrhea. Neurological symptoms may present as tremors, sedation, cognitive slowing, coordination issues, speech difficulties, confusion, and memory impairment. Patients might experience dermatological reactions like acne, hair loss, or rash and may notice metabolic effects such as weight gain. Lithium frequently affects thyroid function, potentially causing hypothyroidism, and commonly elevates white blood cell counts, a condition known as leukocytosis, typically mild and reversible upon dosage adjustment or discontinuation. Lithium therapy may lead to severe adverse reactions, including neurological issues such as lithium toxicity, rare seizures, serotonin syndrome, and pseudotumor cerebri. Renal complications include nephrogenic diabetes insipidus, renal impairment, and potential long-term kidney damage. Cardiovascular effects encompass arrhythmias, sick sinus syndrome, bradycardia, hypotension, and distinctive T-wave ECG changes. Use lithium cautiously in patients with suspected Brugada syndrome or associated risk factors. Additionally, lithium can cause long-term thyroid dysfunction. Clinicians must also remain alert for DRESS syndrome, a rare but serious systemic hypersensitivity reaction. Lithium dosing depends on clinical indications and therapeutic goals. For acute mania, the recommended lithium level is between 1 and 1.5 milliequivalents per liter, while depression typically requires lower levels, ranging from 0.6 to 1.0 milliequivalents per liter. Maintenance therapy aims for lithium levels between 0.7 and 1.0 milliequivalents per liter. Lithium comes in tablets, capsules, and liquid form. Standard initiation is 300 milligrams 2 to 3 times daily, adjusting doses based on measured plasma lithium concentration. Acute manic episodes often require approximately 1,800 milligrams daily, divided throughout the day, whereas maintenance dosing typically ranges from 900 to 1,200 milligrams daily. When prescribing lithium for elderly patients, lower doses are generally needed to achieve therapeutic levels due to increased sensitivity to side effects. These patients face higher risks of neurotoxic effects such as delirium and cognitive impairment, even at standard therapeutic concentrations. Therefore, maintaining lower plasma lithium levels, typically less than 0.6 milliequivalents per liter, is advisable to enhance safety and efficacy. Lithium use in children and adolescents requires caution, especially under age 7, due to limited safety data and higher susceptibility to side effects. necessitating frequent monitoring. During pregnancy, lithium increases the risk of significant birth defects, including cardiac abnormalities like Epstein's anomaly. It may also cause hypotonia in newborns if administered near delivery. Thus, lithium is typically withheld 24 to 48 hours before delivery, with careful fluid monitoring required during labor. Post-delivery, infants should be observed closely for signs of hypotonia, often termed floppy baby syndrome. Due to these risks, atypical antipsychotics are often preferred for managing bipolar disorder during pregnancy. When prescribing lithium, awareness of drug interactions is crucial. NSAIDs, diuretics like thiazides, ACE inhibitors, and metronidazole can elevate lithium concentrations, necessitating careful monitoring. Conversely, acetazolamide, alkalizing agents, xanthine preparations, and urea can reduce lithium levels. Certain medications such as methyl-dopa, carbamazepine, phenytoin, and calcium channel blockers may increase lithium toxicity. Caution is advised when combining lithium with SSRIs due to increased neurological and gastrointestinal symptoms, and with haloperidol due to potential development of neuroleptic malignant-like syndrome. Lithium may also prolong neuromuscular blockade effects. Notably, mood-stabilizing anticonvulsants and atypical antipsychotics do not typically present pharmacokinetic interactions with lithium. In this randomized double-blind study by Patino, the researchers aimed to compare the effectiveness and tolerability of lithium versus quetiapine in adolescents experiencing acute manic or mixed episodes of early course bipolar I disorder. Over 6 weeks, participants were carefully monitored, with lithium levels maintained between 1.0 and 1.2 milliequivalents per liter, and quetiapine doses targeted between 400 and 600 milligrams daily. The study found significant improvements in mania symptoms for both medications. However, Seroquel resulted in greater reduction of symptoms compared to lithium, with a notable earlier response within the first week of treatment. While response rates significantly favored Seroquel, remission rates were not significantly different between the two medications. Both lithium and Seroquel showed distinct side effect profiles. Lithium was associated more frequently with headaches, nausea, and tremors, while Seroquel treatment resulted in higher rates of somnolence, dizziness, and significant weight gain. These differences highlight important considerations for PMHNP clinicians when choosing a medication based on patient-specific tolerability. The study by Bettino had several strengths, including a rigorous design, clear methodology, and an adequate number of participants. However, a notable limitation was the high dropout rate in the lithium group, potentially due to side effects or slower therapeutic response, which affects the generalizability of results. Additionally, the short duration of the study limits the understanding of long-term efficacy and safety. This study highlights the clinical relevance of choosing medication based on patient-specific factors. Seroquel may be preferred for faster symptom relief in acute mania, whereas lithium remains particularly beneficial for individuals with a family history of bipolar disorder or those without prior stimulant use. Lithium's effectiveness in these patients may relate to its unique actions on genetic and neurobiological pathways associated with bipolar disorder, possibly providing a more robust and sustained stabilization of mood. Vigilant monitoring for side effects and patient education about these risk factors is crucial to optimize treatment outcomes. In Fountilaki's systematic review, lithium effectiveness was determined for different periods of bipolar, acute mania, depression phase, and maintenance period. This research included an analysis of hundreds of lithium randomized controlled trials, meta-analyses, and systematic reviews. The systematic review found that lithium was effective for maintenance and acute mania phase, but notably less effective in treating bipolar depression. For this study, we reviewed a 2021 comparative effectiveness report. The study analyzed real-world data from over 13 million patients with bipolar disorder. Lithium was used as the reference drug to compare the long-term safety and effectiveness of 66 different medication regimes, including monotherapy, combination therapy, and polypharmacy. The outcomes reviewed were psychiatric hospitalizations, kidney diseases, and diabetes associated with lithium use. Key findings showed that lithium helped reduce psychiatric hospitalizations and self-harm risk and had lower risk of diabetes compared to antipsychotics. However, it was also associated with significantly higher risk of kidney disease. Other medications like valproate, bupropion, and aripiprazole showed similarly favorable outcomes and fewer physical health risks or side effects. One important limitation is that the data did not come from direct clinical assessments, but insurance claims, so outcomes like self-harm may be underreported. Despite the limitations, the findings support lithium as a highly effective but closely monitored treatment option. The results reinforce the need for personalized prescribing, especially in vulnerable populations or affected by side effects. The next study is a multi-center open randomized clinical trial measuring the effectiveness of lithium prolonged release to resolve the side effects of tremors experienced by those taking lithium immediate release. The reason why tremors is important with lithium immediate release is that the side effect is identified in 27% of patients, which makes a significant prevalence of the side effect. The 27% is a pooled measure. If we looked at multiple individual case studies, then we see a range from 4% to 65% of patients experience tremors when taking immediate release lithium. The tremors are easiest to identify when the patient holds an extremity out against gravity. This should be a symmetrical tremor seen on both sides. These tremors can be identified by the resting state, but will be more apparent during fine motor activity. Basic occupational tasks such as writing or daily activities such as drinking water will develop embarrassment for the patient potentially. The patient will then choose what they feel is the easiest fix, which is self-discontinuation of their medication. The severity of the tremors may result in sudden discontinuation of medication, which will result in recurrence of bipolar disorder symptoms in 60 to 80% of patients. Clinicians have attempted to use beta blockers to counteract the tremors, which can add additional side effects. The transfer from lithium immediate release to prolonged release has a significant impact on reducing the tremors, thus improving medication compliance. After 1 week of switching from lithium immediate release to lithium prolonged release, tremors diminished in 62.9% of patients as compared to 20% of patients that remained on lithium immediate release group. Improvements in tremors continue to improve in 4 to 12 week evaluations. At 12 weeks, 92.6% of patients that switched from lithium immediate release to prolonged release maintained resolution of tremors. This compares to 64.5% of patients without tremors in the group that remained on immediate release. There is not a change in efficacy or safety profile between the two medications. We know that mood disorders increase the risk of suicide, suicide attempts, and self-harm. In 1954, Mogen's show first introduced the idea that lithium held anti-suicidal properties. Since then, there have been several studies and meta-analyses performed to prove or disprove this claim. The study was a systematic review and meta-analysis of studies published between 2000 and 2021. Inclusion criteria required the studies to be peer-reviewed randomized controlled trials that compared lithium with a placebo. Participants were 18 years or older with diagnosed mood disorder. Based on this criteria, there are 11 eligible studies, which included 2,578 eligible participants. The primary outcome interest was number of completed suicides. The secondary outcomes include suicidal ideations and suicidal attempts. Analysis of the suicide occurrences included in all 12 of the eligible trials. 1,278 participants were on lithium and 1,300 were placed on placebo or treatment as usual. Of these, there were 2 completed suicides in the lithium group and 5 in the non-lithium group. The analysis of suicidal behaviors included 7 of the 12 studies and included 1975 participants. 81 participants on lithium took part in some form of non-fatal suicide behavior, either self-harm or suicidal ideations. 85 of the placebo group participants experienced non-fatal suicidal behavior. Although the study did not show a statistically significant decrease in suicides or suicide behaviors, it is important to note that lithium does not increase suicidality of patients or participants. Research demonstrates lithium's effectiveness in treating acute manic episodes, particularly in patients without prior stimulant medication use and with familial bipolar disorder. Adding second-generation antipsychotics can provide quicker symptom resolution. Long-term lithium use significantly decreases psychiatric hospitalizations, making it a highly valuable option for maintenance therapy. While robust in preventing mania, lithium's effectiveness in preventing depression requires further clarification. Current evidence does not strongly support lithium's role in suicide prevention, underscoring the necessity for individualized and ongoing clinical risk assessment in patient management. Lithium therapy requires personalized decision-making tailored to each patient's clinical profile, including factors like family, history, and previous medication use. Switching to prolonged-release formulations can enhance patient comfort and adherence. Regular monitoring of lithium levels, kidney and thyroid health, and patient education on the realistic benefits and limitations of lithium are essential for optimal clinical outcomes. Clinicians must apply evidence thoughtfully, customizing lithium treatment based on individual patient profiles and clinical insights. Acknowledging lithium's limitations, particularly in suicide prevention of depressive episodes, is crucial. Future research should prioritize genetic predictors to refine personalized medicine, investigate long-term safety, and explore adjunctive treatments specifically targeting bipolar depression to enhance patient care and outcomes. In conclusion, lithium remains a cornerstone in managing bipolar disorder, particularly effective in acute mania and long-term prevention of manic episodes and hospitalizations. However, due to its unclear role in suicide prevention and variability in patient response, individualized approaches are essential. Clinicians should focus on careful patient selection, regular monitoring, and detailed patient education when addressing bipolar depression of treatment resistance. Adjunctive therapies should be considered to optimize patient outcomes.